good. Hopefully. Hopefully. Let me just shoot off a quick email to people. Let them know that I'm back up. I don't know what happened there, but it kicked me out.
Thank you.
That time is wrong, right? It's a lot. It's 10. Okay.
Unless you want to.
Wait a minute. You never know. No. We have enough to fill quite a bit of the lecture day. There's so much. Oh, my Lord. So much with respiratory. And I feel like, I was going through, I was like trying to like pare it down. You just can't, It just all builds. Okay. Okay, here we go. So, back we go to here. Okay, so pulmonary capillaries. So if you can imagine once again, we got it down to the alveoli, and we've got this grouping of capillaries around the alveoli, right? So we can have this nice, quick, efficient exchange of gases. So we remember that whole circuit, right? Of the pulmonary circulation. Okay, we've got, I feel like I want to review this. I'm sure a lot of us are strong with it, but if we aren't, let's do a little review. So coming off the heart itself, okay, so from the right ventricle, I think we'll do it this way. Right ventricle is going to send blood to the lungs beginning at the pulmonary trunk. Okay. That pulmonary trunk is going to branch into the pulmonary arteries. Okay, so it's going to bifurcate into the pulmonary arteries. Well, we'll just do it as a chart. Okay, it's going to branch off into pulmonary arteries. And it's just like the systemic circuit. Getting ahead of myself. Pulmonary arteries are going to go to pulmonary arterioles, which are going to be smaller arteries, and those are going to go to capillaries. Okay, and that's where we are in this picture. There's capillaries forming that network around the alveolus. And a capillary, remember, is going to be 1 cell thick. So we have nice quick transmission across that 1 cell thickness of those gases. Okay, so that's what we're looking at here. So blood's going to come from the heart, specifically right ventricle, pulmonary trunk to pulmonary arteries, because don't forget that these are vessels, arteries moving away from the heart. Why might this be confusing for some people? My A&P students have a hard time with this, because what's in this pulmonary artery? Deoxygenated blood, right? Artery's true definition is going to be a vessel moving away from the heart, okay? So pulmonary arteries are going to have does that make sense? Okay, does that make sense? Arteries in this pulmonary circuit, so these pulmonary arteries are going to have deoxygenated blood because it's leaving the heart, the right side of the heart. This is where all the blood has come back from the systemic circuit. We've used up that oxygen. We need to send it to the lungs to get oxygenated, right? So then it's going to return back to the heart, specifically the left atrium, right, by the pulmonary veins. So that blows their mind too, because then those pulmonary veins are going to have oxygen in blood. They're like, whoa, right? But it's the definition of a vein going towards the heart and an artery going away from the heart, okay? So bronchial arteries. So if I were to pop my lungs out of my chest and turn them towards you, we're going to have an area called the hilum, okay? The hilum is where the pulmonary, all the pulmonary vessels and also the bronchioles will go through, okay? So it's grouped in that one area. In that grouping is going to be something called bronchial arteries, okay? The bronchial arteries are what feed the lung tissue itself, okay? Bronchial arteries are what feed and nourish the lung tissue itself. So it doesn't take nutrients from those pulmonary vessels. Okay, it's got to come from those bronchial vessels. Okay, two totally different things. So this pleurae, we talked about those, the viscerals on the organ itself, just like viscera means organ, okay? Parietal means chest wall as a gross generalization. The parietal pleura is going to be on the chest wall, okay? This is where we get them touching. There's a great picture, okay? And well, before I turn the page, the whole premise behind them is to release that serous fluid, okay? And that serous fluid is going to decrease friction, but now we take it one step further. That serous fluid also causes some tension between them and helps to keep the lungs open. Your lungs want to collapse, okay? They want to collapse. We have different things in place that help to keep them open. That surface tension of that serous fluid is one of the things that'll help to keep them open. Are you with me? Okay. Here, this is a great picture of those pleural layers, okay? And they've even cut it out so you can see. Okay, visceral pleura. And, you know, keep in mind, though, they have the pleural space. The pleural space is like, you know, the space between my hands right now. It's not really a true space. It's filled with serous fluid, and those serous membranes are abutting up against each other. Okay, I thought that was a really good picture to help you visualize that. Okay. So I would just take a minute, you know, and review these terms. Because we'll talk about intrapulmonary and intrapleural pressures, right? Okay. So intrapulmonary is going to be inside of the lungs. So we're talking about going down, you know, those bronchioles out to those respiratory bronchioles and the alveoli. What's the pressure basically pushing on the alveoli? Okay, intrapulmonary. I'll tell you what it is in a minute. Intrapleural is going to be the pressure between the visceral and the parietal pleura. Now just think for a minute before we go on. Do we want the pressure to be higher in the intrapulmonary space or the intrapleural space? Absolutely. Intrapulmonary. Once again, your lungs want to collapse, okay? And what happens is we increase the pressure in the intrapulmonary, which is inside the lungs themselves, and what does it do? Right? I'm exaggerating. I always try to do stuff like that to help you remember. Pushes the lungs out. Okay, the intrapleural space is going to be about negative, or 4 millimeters per mercury lower. That's in the notes here, I believe. Okay, we'll talk about that in just a minute. How do you guys say this? F for today, my friend. I'm just kidding. How do you guys say this? Okay, that's how I said it, atelectasis. Atelectasis. I think that's how I was saying in lecture. Have you heard it said that way? He said ascites, by the way. So, anyway, atelectasis. That's how I say it. Have you ever heard it said that way? No? Atelectasis? No? I was taught by professors who were from other countries, so I think sometimes maybe I say things different. But anyway, so whatever that may be, this is going to be a lung collapse. Okay, so a couple things can happen. We can lose that surface tension between those pleural membranes, okay? And that can happen from a couple of different mechanisms. And I think the thing to sort of keep in mind that got refreshed in my mind as I, was working on this is you could have damage from the outside in, right? Somebody comes up and you're working in a prison, they get shanked, right? You know, they stick a knife into their thoracic cavity, they open up the airspace between those pleural membranes and the lung can collapse that way. But the thing that was kind of refreshed in my memory is it can also come from internal, right? If you damage those alveoli and you push air out from them into those membranes, you can also get lung collapse as well if you break those pleural connections, right? Okay, so atelectasis, however you say it, is going to be an injury to the tearing of that visceral pleura, whether from the outside or from the inside. You know, severe lung damage when you get somebody who's really progressed into emphysema. Okay, you get damage to those tissues, it can push through those visceral membranes and the lung can collapse, right? You can also get it from the outside if somebody has some trauma. We can also see this in young men who grow quickly. It happens, does it happen frequently? You guys see it a lot?
Not a lot, but it
Yeah, yeah, especially if they've gone through a quick growth spurt and what's the other pathognomonic sign, and then they go on a plane trip, right? This is, actually seen it a couple times. You know, I had one of my professors tell me, I was like, yeah, whatever. But kids who have a growth spurt and then they go on a plane trip, that lung, that connection between those pleural membranes is not secure yet, and they can have lung collapse, okay? Kind of interesting little thing. I have a little picture there, which is hard to see. People at home, let me bring you in, okay? Oh no, you can see that much better on the screen. I can't see it up here really well, okay? You can see that the nice dark lung field is obviously restricted or what's the word I'm looking for? Compromised, okay? Pneumothorax, right? I guess these can really go hand in hand, right? Because if you get air into the chest cavity, you're probably going to get a collapse of that lung anyway. Oh, we're pretty familiar with this, aren't we? Chest tube to remove it. Pleurisy is going to be inflammation of that pleura. Now, if we think about the mechanisms of inflammation and damage, okay, if inflammation, so some infectious agent makes its way into the pleural membranes, you know, somebody gets pneumonia, you know, bad respiratory infection, whatever it may be, and they get the infection into those serous membranes, what the first thing will happen is they'll stop releasing fluid. Okay, those serous membranes are not going to release fluid, and you're going to get what upon auscultation? A crickling or a friction rub. Okay, if you listen, because they're not in a, are they going to be like real comfortable? These patients, absolutely not. Okay, it's very uncomfortable. That visceral pain, and I was very much reminded when I was in the hospital, is so disconcerting. You know, it really is. You know, those receptors in those organs will send those signals to the brain. And the other thing that's disconcerting, I think, about it, you know, if you get a crick in your neck, you have enough nerves in that area for you to define, I have a crick in my neck. You know, this is a vertebra out of place, which is a misnomer, but, you know, a trigger point, whatever it is. But when you have that visceral pain, you don't have as many per square inch receptors, so you can't differentiate what's going on. And it gives you that kind of like, I don't know what's happening, nervousness, I think, with visceral pain. Okay. So pleurisy is not pleural effusion. What's pleural effusion? Pleural effusion is when we actually start to get fluid, right? Okay. But it can come out of pleurisy if that continues. So we can decrease the production of fluid, then we can get an excess of fluid if we have an over-inflammatory response, you know, kind of moving through the stages. Okay. Pleural effusion can also leak from other locations as well, right? And pleural effusion will start to separate what? Those serous membranes, and we'll start to see it. Where do we see it upon lateral x-ray? Is it going to be more in the anterior or posterior? Posterior, okay? When we look at the lateral recesses of the lungs, let me see if I have a lateral x-ray. I don't think I do. Maybe if we see one as we move along. Oh, maybe I have a picture. Hold on. Pardon me. The lateral oh, I don't. Okay. The lateral recesses are going to be more inferior, okay, than the anterior recesses of the lungs, those little points. So we tend to see it more posteriorly. Very good. Okay. Okay, so process of breathing, it all deals with pressure gradients. Then this is where it starts to get slightly confusing. So if we move into something that you guys don't understand, let me know, okay, and I'll slow it down. Okay, so inspiration. I'm going to bring you guys out and give you my little examples, okay? You know what? I'll draw it. I think I could actually draw this. Okay, so what am I talking about? Okay, I know what I'm talking about. That cold medication today, I'm telling you, it's making me loopy. So if I'm just drawing the thoracic cavity as one big unit, okay? You realize that there's subdivisions, mediastinal and then the two lungs, okay? So when we're looking at the diaphragm in a resting state, the diaphragm is slightly elevated, okay? When you inspire, it contracts and it flattens. So what'll happen is with inspiration, what do we do to the chest cavity? We increase the volume of the chest cavity. We also use, I don't know if I have the external intercostals. The external intercostal muscles, your book actually has this wrong. I was surprised. The external intercostal muscles, if you can think of all my ribs as bucket handles, the external intercostal muscles bring them up and out. So what'll happen is they'll move from like this position to this position. So that will also widen the thoracic cavity, also increasing the volume or the space inside the lungs. Are you with me so far? Okay. So when I increase the space inside of the lungs, I spread the air out. By spreading the air out, I decrease the pressure. Are you with me? Okay. So this whole process is a balance between the external atmospheric pressure and the pressure inside of the lungs. My trachea is open, right? My epiglottis is open, my larynx is resting, so it's open. So I need to somehow change the volume inside of the lungs to get air to passively move in. So I lower the diaphragm, I use my external intercostals to bucket handle my ribs out, and air flows in. Are you with me? Because I've spread the air out, which decreases the pressure of the air. Now the air inside of the lungs is at a lower pressure than the external environment, and air flows in. Do you understand that? It's kind of a tough one. Okay? It's all about changing those pressures. And in order to change those pressures, you got to increase volume, which decreases the compression of that air and allows the air to move from higher to lower pressure inside of the lungs. Okay? Exhalation is much easier, right? Exhalation, the diaphragm moves up, the rib cage bucket handles down. Okay, I say bucket handles because they look like a bucket handle. Ribs do. Okay, they move down and they push the air out. Okay, then I inspire again. Diaphragm moves down, my ribs move out, the volume of my lungs increase. Air moves from the higher atmospheric pressure into the lower pressure of the lungs, and then I squeeze the air out. Does that sort of kind of make sense? Okay. Okay. So it's an active process of moving air. Well, I say active process muscularly, but moving the air is passive. You can't force the air in, right? Okay. Lungs are stretched, intrapulmonary volume. Intrapulmonary volume increases. Oh, volume increases. I'm sorry. Volume increases. Intrapulmonary pressure drops, and this is only, we're dealing with 760 milligrams of, help me out here, of mercury, millimeters of mercury, sorry. Okay, we're only dealing with one degree, okay, 1 millimeter of mercury, okay, is going to create this change, this exchange, okay. So air flows into the lungs down this pressure gradient until that pulmonary pressure is going to equal atmospheric pressure. Okay, then inspiration will stop. Expiration. All those muscles just relax. That's all that happens. There's not a muscle that causes expiration. Diaphragm relax, external intercostal muscles relax, and pushes that air out. Unless it's a forced expiration. Okay, then we start to trigger in what are called internal intercostals. And we'll see that with people who have, compromised breathing, COPDs, right? Right. So volume decreases, elastic. Don't forget that the lungs are full of that elastic fibers. They recoil, and intrapulmonary volume decreases. Pulmonary pressure rises by 1 millimeter of mercury. I keep wanting to throw a degree in there. That's why it's throwing me. Air flows out of the lungs. Okay, so that's it. It's amazing to me. Okay. Physical factors. Okay, so inspiration, has to fight airway resistance. So what's going to increase our airway resistance? And this is where we start to get into those applications. A couple of different things, right? Actual size of the passages. Asthmatics, perfect example. they're small, okay? They get constricted. They can't get the air in and out. But what's going to be another thing other than size of the bronchi or bronchioles? What else would increase airway resistance? Mucus, okay? Absolutely. People with chronic bronchitis are going to have extra deposition of mucus. That'll decrease, it'll create more of a resistance. It's part of their problem, okay? Alveolar surface tension, okay? And lung compliance itself. If people are exposed to, what's that one, mesothelioma, right? They're exposed to those chemical agents, it creates a fibrosing in their lungs. They're not able to open and recoil their lungs as efficiently as if they were healthy, okay? A lot of things can happen. So, atmospheric pressure. So atmospheric pressure is approximately 760, oh, people at home, let me bring you in. 760 millimeters per mercury. Okay, so we're just changing 1 millimeter per mercury with respiration, or ventilation, I should say. Okay, in and out. Okay. The pressure in the pleura is usually 4 millimeters per mercury less. So let's just think about that for a second. And do I have another picture in here? Here, let's look at this. Look at this picture. We've got the visceral pleura. We've got the parietal pleura right up against each other. If you imagine that little picture, okay, where at the bottom there where it says 760, or that little arrow, okay, so it has 760 millimeters per mercury of pressure. Is that higher or lower than 756? Obviously, I know I'm asking you stupid questions, but I'm trying to make a really difficult concept easier to understand. It's going to be higher. So the lungs are going to push out with 760 millimeters of mercury of pressure. The pressure pushing apart those pleural membranes is only 756. So who's going to win? 760 is going to be stronger or more pressure, so it's going to push the lungs out, because the pressure between those pleural membranes is not strong enough to push against the 760. Are you with me? Does that sort of kind of make sense? Okay. And it'll push the lungs open. That's why if somebody, heaven forbid, gets fluid or water into that pleural space, okay, if it's open to the atmosphere, or if it has fluid in there, so it supersedes, or it's more than that 760 inside the lungs, it's going to collapse the lung, isn't it? Okay, it's going to collapse the lung. I think this is a really great picture. This is hard. If you guys don't understand this, please let me know. Okay, but the main concept, I think, if you could get it into your head, if you get into your head that we need to keep the lungs open, so the pressure in the lungs has to be higher. Done. We need to keep the lungs open, so the pressure in the lungs has to be higher. Done. So that way, if you get something that's going to open up that pleural membrane and separate it, it's going to push in on the lungs and collapse it. Okay? And once again, there's several things that can happen, right? Several. That's why when I was preparing this, I didn't want to just go through like one disease after another. I think if you understand the mechanisms, you could figure out the disease processes, you know? Okay? Does that sort of kind of make sense? Okay, please, if it doesn't, please, please, please let me know, okay? So diaphragm and external intercostals we talked about with inspiration. This is a great picture. A lot of these pictures came from my A&P book. Okay, so hopefully if you can't see them, hopefully you could, you know, upload them on your screen and open them up and look at them a little bit closer. You can see the diaphragm will move down, okay, allow an increase in volume. Those external intercostals will kind of pull the ribs up and out, okay? Inspiration, expiration. Why did I do this again? I don't know. There you go. There's another explanation. Freebie. Oh, I have it in twice. That's weird. I don't know why I didn't catch it when I was redoing the notes. Respiratory volumes. Do you guys work a lot with spirometry? A little bit? Yeah? Okay. So just briefly, I want to go through these volumes for people who are not familiar with it, if they're in a different specialty, okay? And just what they mean. So, normal breathing. Normal breathing is going to be your tidal volume. So every time you just were hanging out here, well, you guys more than me, right? Because I need to go above and beyond because I'm lecturing. But you're hanging out, you're listening to what I'm saying, hopefully. Got your coffee, doing whatever. Tidal volume is going to be that normal inspiration in and out. It's going to be about 500 milliliters. If you need to take deeper breaths for whatever reason, you know, I'm trying to project, I'm breathing above and beyond what I normally breathe, you go to exercise, you know, whatever. You start to move into those reserve volumes. Okay, there's an inspiratory reserve and there's an expiratory reserve, which is common sense. It's going to be the air above and beyond your normal everyday breathing or below your normal everyday breathing. And it gives us larger capabilities to bring and expel more air if we're active, okay? Because you need to bring in that oxygen to make energy, okay? So inspiratory reserve and expiratory reserve, I'm not even going to get into the volumes. I mean, if you're familiar with it, great. Now, why do we have a residual volume, though? What's the residual volume? Do we know? Okay, so let's move further in the notes. Okay, here's a whole chart. I'm not going to ask you numbers. I want you to understand those brief concepts that I just went over, okay? So, I hope I have it in here. Oh, I don't have it. Okay, so let me just tell you what residual volume is. Might want to put it on here because I think it completes this. Residual volume, if you take a deep breath in, you let it all the way up. I can't breathe out any more air. There's air left, right? Why is there air left? That air that's left is called residual volume. You can see it on the chart there. It's not in the notes, so you might want to add it. I think that's a good thing to add. Residual volume, if it's not ringing a bell. Okay, residual volume is going to be air that's left in the lungs so the lungs don't collapse, okay? So the lungs don't collapse. Those alveoli are only one cell thick. Yeah, if they got close to each other, bam, they would just collapse, okay? So residual volume helps to keep it open. Do you want to say something? You look
your dead space, your air, which is
right. It's the dead space. Oh, I see what you're saying. It is in the notes. Yeah, but I actually wanted to define it specifically. And what he's saying is on the next slide forward is it's going to be the anatomical dead space, right? So if your tidal volume is 500, only 350 milliliters is going to be actually exchanging gas because you have that dead space, and that dead space is the residual volume. Yes, thank you. Okay, and keep in mind there's some left in the airways too, right? Okay. Well, actually, no, I'm sorry. I take it back. You're throwing me off here a little bit. Anatomical dead space is going to be that's left in the airways as opposed to residual volume. I see the correlation that you were trying to draw and you actually sucked me into it. But anatomical dead space is going to be, see, it's that cold medicine, I'm telling you. Thank God I took it because I was like in a fog earlier, but now I'm like the opposite end. Anatomical dead space is that which is left over in the airways. Okay.
so that's not
No. Residual volume is what is left in the alveoli after expiration. So anatomical dead space is going to be what is left in the airways that is not exchanging with the alveoli or the bronchioles, the respiratory bronchioles, right? So I inspire 500 milliliters. I'm just giving an approximate. Whatever's left in my trachea and my bronchi aren't going to be exchanging gas because it can't cross those membranes. Are you with me? Okay. It's only going to be the active air that'll make it down into the alveoli where we exchange the gas. So anatomical dead space is going to be the air that's left in the trachea, the bronchi, the areas that we won't exchange gases. Okay? And if you get into respiratory, it's so complex, all these different tasks to tell are you in respiratory? Is that how you?
No, I just orthopedic surgery. So.
Oh, okay, yeah. There's a lot to it, right? Okay, so anatomical dead space is not, sorry about that. I blame it on the cold medication and the caffeine. Anatomical dead space is not going to be residual volume, okay? Okay, good. So pulmonary function test, it's spirometry. I think this is all right, pretty bread and butter stuff. It's going to differentiate between those COPDs, and your book went through a whole list of all different names for COPDs now, which I'm going with COPD, okay, for now. And then restrictive disorders, which will be some sort of damage to the functional structure of the lung itself, as opposed to damage to the airways with the COPDs. Okay, so spirometry can differentiate between them. Just some, I don't know if you need to know these, and they're probably all familiar, so I'll go through them. Minute ventilation is going to obviously it's going to be ventilation during a minute. Forced vital capacity is gas forcibly expelled after taking a deep breath. That's when they go, 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 go. You know, they're trying to get you to get all the lung volumes out, as opposed to FEV, which is usually FEV1, right? This is going to be the amount forcibly expelled within not a minute, a second, okay? And that should be approximately what of your lung volume? FEV1, do you guys remember? It's about 80%, I believe, around 80%. I can't remember if it's 70 or 80, okay? But you should be able to, of your total lung volume, okay, other than that residual volume, get out about 70 to 80%. If anybody knows the exact number, let me know, of your lung volume within a second, okay? Okay, good. So, non-respiratory air movements, coughing, sneezing, crying, laughing, hiccups, and yawns, okay? Coughing is going to be obviously reflexive to get rid of substances. Sneezes, same thing, particulate matter gets in the back of the nose. You sneeze to try to expel it. Crying, we don't actually know why we cry, and we don't know why we breathe so deeply when we cry, but we do. Laughing, hiccups are going to be reflexive spasms of the diaphragm. Okay. And yawns. Yawns are usually due to being tired, but also trying to clear some CO2 from our system. Okay, so nervous system. Nervous system is going to help to regulate our breathing. We can consciously control our respiration. You know, if you go into, which is a good thing, if you go into meditation, meditation will stimulate the parasympathetic nervous system when you move into deep breathing. Did you guys know that? And parasympathetic is that calming part of the nervous system. So even if you don't have a lot of time to meditate, just sitting and taking 3, 4, 5, 10 deep breaths will kick in your parasympathetic, the calm part of your nervous system. Okay, so kind of a cool little thing. But we also have areas that will just maintain respiration on their own. Okay, do you guys remember the pons and the medulla? Those are going to be two major centers for regulating breathing, regulating respiration. Now, the thing to remember is CO2 is going to drive breathing. Okay, and we talked about that before, okay? CO2 levels, our brain will monitor CO2 levels in the blood. That is what's going to drive our breathing. That's where you get that when people are starting to die. They build up CO2, their breathing kicks in, they clear it, and what do they start to do again? Stop breathing, right? CO2 builds and they breathe again. That's what's happening. It's our body's trying to clear that CO2, okay? Now, the breakdown here is a breakdown of, percentages. I mean, we all probably know 20% of oxygen's in the air, right? Yeah, okay. So partial pressure of oxygen. When we talk about the partial pressures of oxygen and carbon dioxide, what's important to understand is that oxygen is going to be at a higher concentration in the alveoli. Okay, so we don't have active mechanisms on the membranes between the alveoli and the capillaries. It's going to be a passive diffusion, and oxygen will passively move from the alveoli into the bloodstream. Carbon dioxide, being at a higher concentration in the blood, is going to move from the blood or those capillaries into the alveoli to be expired. Are you with me? Okay. So all of these, and what they talk about with partial pressure is the pressure of that gas within either the fluid or the air that it's in. So if it's at a higher partial pressure, and partial pressure gets into all the different gases that are in that gas or in that fluid, and it gets a little crazy. What I want you to understand is that oxygen is going to be at a higher concentration after we inspired, right? So we take a deep breath in, oxygen will be at a higher concentration in the alveoli and be forced into the blood. Carbon dioxide is going to be at a higher concentration in the blood and it'll be forced into the alveoli. That's what I want you to understand, okay? That's what I want you to understand. Now, oxygen is going to be transported on hemoglobin. So if we look at a red blood cell, okay, You can imagine they've got a little part of some sort of vessel cut open. I'm not sure if that's probably an arterial, I'm not sure. And they've taken a red blood cell out, okay? And inside of that red blood cell, we've got hemoglobin units. Okay, you with me? On the center of the hemoglobin units, there's actually 4 of them per hemoglobin unit, but don't worry about it, is iron. And attached to that iron is, or hopefully, if we get enough of it, is oxygen. Okay? So on each hemoglobin unit, we're going to have 4 oxygen. Are you with me? Okay. Inside of each red blood cell, we're going to have hundreds of thousands of hemoglobins. So what will happen is these red blood cells with the hemoglobin will pass by those pulmonary capillaries, offload carbon dioxide, and pick up oxygen. And the important thing to also remember is that the red blood cells don't leave the blood vessel. They stay in the blood vessel. It's just the gases that pass those membranes. Okay? Then when the red blood cells get to the capillaries, so they travel through the body, they go to the lungs, they get oxygen, the red blood cells, they go to the heart pumps it out to the body, these red blood cells move to the tissues, they stay in the capillaries once again. They're not going to leave the tissues. And they'll exchange oxygen, get rid of oxygen, and take the carbon dioxide into them. Okay, so red blood cells stay in the blood vessels, they don't leave. Okay, no hemoglobin. So oxygen transport. So when we load oxygen onto this hemoglobin, when it's fully saturated, all 4 of those iron units, it's called oxyhemoglobin. If we unload the oxygen, it's now called what? Deoxyhemoglobin. It's not that complex, so don't let it blow your brain, okay? If it's saturated, it's oxyhemoglobin. If one is coming off, it's deoxyhemoglobin, okay? Usually going to be on those 4 iron and those hemoglobin units. But the thing is, when, sorry, I just thought of something else I want to talk about. We circulate a red blood cell through, okay? It only unloads 25% of its oxygen. We keep 75%. That's our venous reserve. So we don't send a red blood cell out and it dumps off all of its oxygen. We keep a venous reserve as a backup plan, right? God forbid, okay? So we're going to return about 75% of that oxygenated blood back to the heart. That's why they tell us to do what now? Instead of mouth to mouth, just do chest pumps, right? Okay. So 98.5% of oxygen will be transported on the hemoglobin that we just talked about, on that little iron unit. That's why when people are iron deficient, they become anemic, because you need that iron in the center of the hemoglobin to attach the oxygen to. Okay. We can also have free oxygen just found in the plasma. Bohr effect, does that ring a bell at all? Okay. Bohr effect. When there is an increase of carbon dioxide, we're more apt to offload oxygen. Well, that makes sense, doesn't it? Okay, because if we have an increase in carbon dioxide, we're going to want to release oxygen, that carbon dioxide, and get rid of it. Okay? Bohr effect. Okay, here's our little picture of hemoglobin that we went through. Any questions so far? Okay. Homeostatic imbalances. So this is common sense, right? Hypoxia, inadequate oxygen, too few red blood cells, abnormal too little hemoglobin, blocked circulation, metabolic poisons. This all makes sense, right? Do you guys know why carbon monoxide is bad, though? Physiology? It does. It kicks oxygen off those iron units, and it takes its place, and it doesn't like to leave. And the other bad thing about carbon monoxide is it makes people look what? Flushed, right? So it doesn't make sense that they're hypoxic. Good. Okay, so carbon monoxide. Carbon dioxide transport. So we've offloaded the oxygen. It primarily is going to travel on that iron unit in the hemoglobin. Some of it's found free in the plasma, okay? There are 3 ways now that we're going to collect this carbon dioxide and return it to the lungs to be excreted. Okay, so there's 3 different ways. On hemoglobin, It'll actually go on a different part. It won't go on the iron. It goes on the globin part. It's called, don't worry about that. Just know it goes on a different part of the hemoglobin and travels back. In the plasma, okay, about 10%. But most of it's going to move into that buffer system. Okay, bicarbonate, right, carbonic acid. So carbon dioxide mixes with water. It'll be transformed into carbon dioxide. For those of you who hate chemistry, don't fear this. Just look at this moving from left to right. Okay, so we need to get rid of carbon dioxide. We'll bring it into the red blood cell. Okay, we're actually bringing it into the red blood cell, and we'll move it through this process of combining carbon dioxide with water. When you combine them, it turns into carbonic acid. How do I know that? Because we have all the atoms that we started with. We have 1 carbon. We have 3 oxygen. We have 2 hydrogen. Okay? And that is carbonic acid, H2CO3. We've just combined CO2 with H2O to form carbonic acid. Okay? That carbonic acid our body likes to turn into bicarb. Okay? Bicarb is just a little bit easier for us to send through our system. Okay? Carbon dioxide is bad. Do you guys know? It's not bad. I take that back. In high levels, carbon dioxide is bad. Why is it bad? Why? It makes you acidotic, right? It's going to send you into respiratory acidosis. So we buffer it. We turn it into bicarb. Okay, we turn it into bicarb. And then we could send it back, can't we? Right? If we become too alkalinic, we could send it the other way. Who's going to be the other main system when we're going to deal with acid base? Kidneys. Very good. Oh, I love teaching you guys. Make it easy. Okay, so good. So we're going to buffer that by turning it into carbonic acid first and turning it into bicarb. Okay? And that's how the majority of carbon dioxide is going to be sent to that pulmonary, to those pulmonary capillaries. And then the reverse process happens. Okay? Bicarbonate is going to be put into red blood cells, which will change it back into CO2 and shuffle it right across the membrane into the alveoli. Gone. Done. Okay? It's not that hard, right? And this is why with ketoacidosis and also kidney problems, right, we see people start to use respiratory means to try to get rid of that acidity. Okay, okay, great. So neural and chemical control of respiration. Neural mechanisms are going to be those reflexive mechanisms that we'll find in the medulla oblongata and the pons. Chemical mechanisms will be primarily the monitoring of what? Carbon dioxide. Okay, monitoring the levels of carbon dioxide is going to be a huge part of it. Oh, and here they are. So, you don't need to know the breakdown of dorsal and ventral. I memorize that and I forget it all the time. But remember that the medulla and the pons are going to be 2 of the main areas that are going to help with respiration, okay? Eupnea, okay, we know that EU means normal, right? Eupnea is going to be normal breathing. You are, always remember it by you are normal. Eupnea is going to be normal breathing. Conduct pulses every 4 to 5 seconds. We get 12 to 15 breaths per minute blown through it because I know you guys probably know it, okay? Hypothalamus can create emotional changes. You know, if somebody gets really distressed, their respiration or their breathing can change, okay? But primarily the everyday breathing is going to be maintained by the pons and the medulla oblongata. And we do have conscious control. You know, we can consciously change our breathing. Chemical receptors, so carbon dioxide and oxygen levels will help to balance, will help to create balance with that. CO2 is more acidic. We have O2 sensors in the aortic and the carotid bodies. These are going to be receptors that are going to be right in the aorta, and the carotids, I believe they're right at the bifurcation of the carotids as they turn into the internal and the external, okay? Aortic is sensed by cranial nerve 10. Are you cringing again, talking about cranial nerves? I love cranial nerves. I would love to teach neural. I think that would be so amazing. What? Accessory. Right. So carotids are sensed by cranial nerve 9. Exhaling more often will decrease the level of acidity in the body. There's different theories about how acidity is like bad and you should breathe more to get rid of the acidity, but you know what? Your body's going to buffer you right back to 735 to 745. So I don't know. Maybe I don't know enough about that. When levels reach critical status, we will inhale. This is why drowning victims, you find water in their lungs. Okay, reflexively, it's, you know, same thing with your kids. Mom, I'm gonna hold my breath until I get, okay. You know, people probably think I'm the meanest mom in the world because I'm, okay, hold your breath. Let's see how that goes for you. After a while, they're gonna inhale, right? CO2 is gonna reach a critical status. They're gonna inhale. The little buggers, okay? We talked about this as well. Okay, quick little 5-minute break again, and then we'll finish up the rest of this lecture. I may need 10 minutes. Okay, I want to check a few things and go to the ladies' room. All right, I will check emails too. Let me know if you have any questions. We go to 11:40, right? Oh, I got to change that clock in the back. It's throwing me off. 10:46. Okay.